Welcome to The Explainer. Today, we're diving into two types of lower leg fractures that, while they happen right next to each other, are just worlds apart when it comes to how we treat them. We're talking about the tibial shaft fracture and the pilon fracture. We're going to break down why one gets an intramedullary nail and the other needs a whole different playbook with plates and screws. And really, it all boils down to the pathomechanics.
Okay, let's get right into it. The whole point here is understanding the massive difference between a fracture in the middle of the tibial shaft versus a high-energy pilon fracture that just shatters the ankle's joint surface. You'll see that the location and, maybe even more importantly, the mechanism of the injury are the two things that dictate our entire surgical strategy.
So first up, let's talk about diaphyseal fractures. These are injuries to the shaft, the long, straight part of the tibia and fibula. This is what most people picture when they think of a classic broken leg. Now, the tibia's anatomy is everything here. Of course, it's the main weight-bearing bone, so it's already under a ton of stress. But the really crucial part is that its anterior surface is subcutaneous. I mean, there's barely anything, just a thin layer of skin between that bone and the outside world. And that anatomical vulnerability, that's exactly why it's so prone to becoming an open fracture.
And this number, 20%, is a huge deal clinically. Think about it, up to 1 in 5 of these fractures are open. That immediately changes the entire game. We're not just fixing a broken bone anymore, we're now up against a high risk of osteomyelitis, which means that patient is going straight to the OR for an emergent irrigation and debridement.
So this really lays out the standard of care for us. I mean, sure, a cast might be an option for those really rare, stable, perfectly non-displaced fractures, but that is absolutely the exception. For the vast majority of tibial shaft fractures, surgery is the definitive treatment. And the intramedullary nail is the absolute workhorse for these fractures, and for good reason. By placing it right down the medullary canal, it acts as a load-sharing device. So what does that mean? It means it shares the body's weight with the bone itself, which is perfect for promoting callus formation and healing. This stable internal splint is what allows for early weight-bearing and mobilization, and that is just critical for getting patients back on their feet.
All right, now let's completely switch gears and see how this contrasts with our second injury, the pilon fracture. We're moving from the shaft way down to the tibial plafond, the very end of the bone that makes up the roof of the ankle joint. The mechanism here is totally different. This is not some simple twisting injury. This is a high-energy axial load. I want you to picture a fall from a height, where the talus slams up into the distal tibia like a pestle into a mortar. It just causes the articular surface to literally explode.
And clinically, these are just devastating injuries. The ankle often looks completely disfigured, and with the sheer force involved, it's really common for bone fragments to just pop right through the skin, creating an open fracture. You can just imagine, the soft tissue envelope takes a massive hit, and that's a huge consideration for when we can even think about doing surgery.
Now, with these incredibly complex articular fractures, an intramedullary nail is, well, it's useless. It can't possibly fix a shattered joint surface. So our whole approach has to shift to extramedullary fixation using locking plates and screws. The number one goal here is perfect anatomical reduction of that joint surface. Why? Because any little bit of incongruity can lead to painful, debilitating post-traumatic arthritis down the road. Precision is everything.
Okay, so let's pull all of this together now and really compare these two fracture patterns and their treatments side by side.
So here's the breakdown, the bottom line. You've got a diaphyseal fracture in the shaft from a direct or indirect force. It gets an intramedullary nail. You've got a pilon fracture at the tibial plafond from a massive axial load. It gets locking plates. You can see it right here. The location and the mechanism of injury are the two variables that directly tell us which implant to use. It's as simple as that.
All right, so let's wrap this up. What are the most important points to walk away with? Let's run through the essential clinical pearls you need to know.
Okay, here are the absolute must-knows. Diaphyseal fractures, think shaft injury, think intramedullary nail. Pilon fractures, think intra-articular, think plates and screws for a perfect reconstruction. Always consider the mechanism of injury. It will help you predict the fracture pattern. And don't forget that subcutaneous tibia, leading to that 20% open fracture rate. And one final clinical pearl for you, in an isolated tibial shaft fracture, we generally don't need to fix the fibula.
So I want to leave you with this final question to really chew on. Think about the biomechanics here. Why is a central, load-sharing nail the perfect implant for a diaphyseal fracture?
while a peripheral load-bearing plate is absolutely necessary to reconstruct a shattered joint surface. If you can really understand the answer to that, you've grasped the fundamental principles of fracture fixation.